everybody, it's Dr. V with the Veterinary Telemedicine Facebook community, and today's interview is one I've been looking forward to for a really long time. I have Liz Hughston, who is a credentialed veterinary technician, probably one of the preeminent technicians in the world. You've seen her lecture everywhere on all sorts of things, and I'm so grateful that she agreed to come and talk to me today. So thank you
so much for having me. I'm so excited to be here. It's so great to talk to you. And this is a topic that is near and dear to my heart. So it's a perfect fit for telemedicine, telehealth, and I'm super excited to talk about it.
Yes. And so, we've been having so many conversations in the group about workflow and, what's the handoff from the CSR to the doctor and the doctor to the client, and like over and over again, they're talking about the difficulty in that handoff. I'm like, well, I feel like there's another group here.
There's a tiny missing piece that, and I think the doctors don't think about us because we are busy doing the other things in the hospital, right? If it's a well-managed practice, the technicians are being hopefully well utilized in doing the actual technical work in the practice. They are providing nursing care, they're anesthetizing patients, they're recovering patients, they're doing client education. So I think that when we think about the phone, we don't naturally think about the technician or the assistant and their role and value in that communication structure.
And that's always so interesting to me, because when I think back on my clinical career, I had a technician, and like my entire clinical career was defined by my relationship with her. Like we started together. I was a new grad, she was a new assistant, and then she went on, she became an RBT. It was amazing, and we just kind of went as a team from hospital to hospital, and that was sort of the unit. And one of the best things about having her there, and just, being like an incredibly competent person that I couldn't function without, was she could communicate in such a great way. So I guess I'm not even sure how you work at maximum efficiency if you don't have that sort of in the mix, because to me there's so many things. That's one of the great things about technicians, right? Is I feel like you guys are oftentimes much better communicators in terms of really managing sort of the client experience and being patient.
Yeah, I think just like doctors, I think there's a spectrum. And some of us are much better at talking to clients and doing that client education piece than others, but it's no different when you look at a doctor either. It's the same, right? Some veterinarians are incredibly deft and adept at that communication piece. And the empathy and all of those things that are required to really strengthen that relationship with the human that's on the other end of the leash or the carrier. And technicians are the same, and assistants. I think technicians and assistants have a lot of strengths in those areas, because we do have to communicate with lots of different people in our regular roles. Anyway, a technician who's not a good communicator is not going to be a technician for very long, I think. Okay. And so, but I think some of us are better at it than others. Some of us are better at it in person. Some of us are better at it on the phone. Some of us really aren't good at talking to clients. And I think that when we look at this new world, I guess, that we're in, this new future where we're all trying to figure out the best way to take care of pets and their owners through this pandemic, through the fear, through the changes in all of our protocols, through this shift to more remote care. So telemedicine, telehealth, tele-advice, whatever it is you want to call it, finding ways to maintain those relationships. And I think that the technician is really a natural part of that, or should be a natural part of that, because I think of an example, like a newly diagnosed diabetic, for example. The doctor is going to talk to that owner about what diabetes is, how they came to the diagnosis, what the diagnosis means, what the prognosis is, what kind of care is going to be needed, but it's the technician, or it should be, who's in there doing the education, talking about how you pull up the medication, where you keep your insulin, what signs to look for that tell you your pet is having a crisis and they need to be seen emergently. And so really technicians are already doing a lot of that work, and shifting it into the virtual or the video or the telephone sphere is a natural progression, I think, if you already have a crop of well-trained, well-educated, and experienced technicians.
Yeah, and I think that's such an important point, because when we talk about sort of this umbrella of virtual care, I think, you know, as doctors, we tend to fixate on VCPR and what can I do, and the medicine, and that's like one part, right? And there's so many other parts that we're taking responsibility for, that we shouldn't, probably because like it's not efficient, and there are other people that could do it better. But I think we just need to sort of lay out all of those different parts of it, and not just in the virtual world, you know, just in the clinic, the same sort of thing happens, right? But somebody calls and they say, my dog is vomiting and I want to talk to the doctor. And so then they just, CSR goes and grabs the doctor. But like, just because they demand it doesn't necessarily mean that's what should happen.
Right, exactly. And I think that there's a lot of things that have to be considered for clinics who are thinking about moving to telemedicine or incorporating more telemedicine in what they're already doing. And I think that, you know, one of, like we were talking about before we started the call, in the group, we talk a lot about that flow, the workflow. How does this work? What do I do? So the client calls and demands to talk to the doctor because their dog is vomiting. The CSR has, you know, 14 other phone calls plus a bunch of cars, you know, in the parking lot waiting for their curbside service, and they're trying to manage all of that. And no matter how skilled or experienced they are and how much they may know what the doctor is likely to say to that client, they don't have the time or necessarily the expertise to have those conversations. And we shouldn't put the burden on them to do that. They already have enough on their plate. But the technician is or well-trained, well-qualified assistant is the perfect middle place to say, let me put you on the phone with, you know, our teletriage department, or our, you know, technician who's taking these advice calls today, and they can talk you through what's going on, and then we can determine if we need the doctor. But if we need the doctor, then what's probably going to need to happen is you're going to need to come down and see the doctor in person. But the technician or assistant, whoever's doing the tech calls or advice calls or whatever you want to call them, can help determine that situation. And I know a lot of people talk about the danger of relying on owner reporting when it comes to telehealth and telemedicine, and a call like that, teletriage, my dog is vomiting. And we all know in veterinary medicine, you know, I've been a veterinary technician now for 16 years, well, 14 technically, because I graduated in 2006, but so we know vomiting it could be anything. It could be Addison's disease. It could be a foreign body. It could be parvo. It could be, you know, megaesophagus. Maybe it's not vomiting at all. Maybe it's regurgitation. It could be any number of things. It could be, you know, gastroenteritis. So we need to, I think about this in the same context as pediatricians, and especially with this pandemic, telehealth in pediatrics has really taken off. And it's the exact same situation. You're dealing with a nonverbal patient, and you're relying on a caretaker to communicate the clinical signs that they are seeing. And then you have to make a determination as to whether this is something that needs to be seen in person, or if you can make a determination over the phone based on your education, your clinical experience, and the likelihood of what conditions you might be seeing based on signalment and all of those things. But that is what we're all trained to do. And the idea, we do that in the office, we do that in person, right? Even when you can put your hands on a dog or a cat, you don't know for sure what's going on with them because you're still relying on the pet parent or owner to explain to you the clinical signs of concern that brought that animal to you in the first place. So I think if we look to pediatrics, I think that is a parallel for us to really take a lot of lessons from, and they're doing this quite successfully in pediatrics. And I think that and we all know if you are part of a health maintenance organization or a care group, you don't talk to the doctor first thing.
Right.
That's not what happens, right? You don't get to call and talk directly to your doctor unless you have some fancy concierge medical service. You call and talk to a nurse, an advice nurse, and they then tell you, they either consult with the doctor and then provide you with information, or decide, no, you need to talk to the doctor, or no, you need to come in and be seen. And I think the parallels are very, very strong for us. And I think that people who aren't using their technicians in that type of advice nurse role are really, they're really cutting out a lot of efficiency in their practice.
Yes.
And I think you can use them in that way to really help winnow down those calls that the doctor needs to take. That's been my experience.
Yeah.
And I think doctors nowadays especially would like to lessen their workload a little bit in that way.
Yeah. And I'm so glad, right. I'm so glad that you brought up the nurses and the pediatric nurses. My mother was a pediatric RN for 30 years, and she launched the Scripps here in San Diego, Scripps Nurse Advice Line. And I mean, I don't know if people understand, when you call, or especially for me, like I'm not trained to triage. So if a client gets on the phone with me, I'm thinking in my head, like A, B, and C. These nurses, man, they have clinical algorithms that are 10 pages long, and they're validated, and they are going to get a much more consistent, outcome in terms of what you're supposed to do. And they never say it's this, out of the other, but they're able to tell you emergency, come in today, come in tomorrow. You don't have to come in. And that alone, huge value.
And that is such an interesting point, the difference between the way a doctor's mind works and a technician's mind works, right? So
I'm automatically worst case scenario, like, that's blow.
And you're automatically on those algorithms, right? Your brain is going down the algorithm of your diagnostic algorithm. So you're already thinking about what diagnostic test you're going to need to run, what you need to know, right? Whereas as a technician, I'm coming at it from, what are you seeing? What are you concerned about what you're seeing? And do those signs actually mean a doctor needs to do a bunch of diagnostics? Do I need the doctor's brain to come in here and take this over and figure out what's going on? Or is this something that an owner can wait and see? Can they, or a pet parent, whatever term it is you want to use, and kind of maybe pet parent is a better term, because if we're going to compare it to pediatrics, maybe that makes it a little more emotional.
Whatever you like.
But to let them know, hey, this is something you can wait on. And here are the signs I want you to look for that are going to be of more concern for us. And if you see any of those, then that's going to mean you're going to need to come in, or we're going to need another phone call because you're going to have to talk to the doctor. But think about all of the times, those of you who are watching this, think about all of those times as you as a veterinarian were on that phone call, and when you hung up, thought that was 20 minutes of my time that really didn't need to be 20 minutes of my time. Yes, it's nice for me to talk to clients, and yes, it's great to form those bonds between veterinarian and client. But that was 20 minutes that I could have actually done an in-person visit, or I could have been providing, emergency care for an animal, or I could have been doing surgery, those things that are really making the practice revenue. And my expertise wasn't actually required for this phone call. This could have been handled by a well-educated, experienced, you know, technician or assistant.
Yeah.
And I think
No,
that
and
happens a lot.
oh, yeah, all the time, all the time. And I think because there isn't sort of that structured workflow in place, and I think because I didn't realize this when I started, I spent a year working with Whisker Docs, which is a tele-advice line. And again, they had veterinarians and they had technicians working at the exact same level in terms of outcome, satisfaction, clinical outcomes. And the algorithms were so structured in terms of, you know, you have your expertise, right, to sort of help you go in the right direction, but just realizing that, you know, oh yeah, I forgot about, you know, these little things, and making sure like this is something that you can train.
Right.
You can train someone.
100%. And I know a lot of people think, oh, they don't have time to train because they're so busy, right? This is a common theme in veterinary medicine. And I think that a way to do this, to get started, to get your feet wet, is start with really easy things. So start letting your technicians and assistants call owners back or pet parents back about normal test results. So I think that is a huge use of technicians and assistants that maybe some practices aren't doing. If you're not, my God, don't have your CSRs be doing these. It's ridiculous. They have enough on their plate, like we've already talked about. It's a perfect thing for an assistant or a technician to do. And it's an easy way to get started to see how it's going to go, and to start with training that communication over the phone. Because I think about this when I hear new assistants or new technicians call about heartworm tests, for example, or fecal results. And they'll say, oh, so the fecal results were negative. And then there's a pause. And they're like, no, that's a good thing. So like that's a training point, right? So you don't call and say the test was positive or negative. You say, so we didn't find any parasites. And that, you know, and so, but that is such an easy way to start the training, to start getting people used to talking to pet parents on the phone, to start getting doctors used to the idea of using technicians and assistants in that way. And then I think the next normal step from that is, or a, you know, logical step from that is surgery follow-up. So a callback on a neuter or a mass removal or you know, a dental procedure. So a callback to say, hey, we did Buster's procedure yesterday. How did he recover from that? Did he eat his dinner last night? Did he eat breakfast this morning? Is he taking his medication? And the great thing about that is, I mean, I have done those calls and been on the call for like 40 minutes because we're talking about not just Buster, but what's the best way to get him to take his pills? And, oh, also, you know, he's doing this, or his sister is doing something else. And do I need to bring, so sometimes those can kind of morph into something larger. And again, I think you as a veterinarian know that's what happens when you get on the phone with pet parents, right? Is it always morphs into something beyond what you expected it to be?
Yeah. And you know, we don't want to hang up, right? Because I think we intuitively know this isn't valuable to me, but it is very valuable. And so I can't not address those things. But
right. And I
really
think
would
that
like to be there petting.
and I don't, yeah. And I don't want to be mean or dismissive, but I think for most pet parents, it doesn't matter to them if the person they're talking to is the veterinarian or the veterinary technician or assistant. What matters to them is they have a person at the veterinary hospital or facility that is a trained professional that they can talk to about their concerns, if they have concerns, or who has called them to make sure that their pet is doing okay after a procedure. And in my experience, nobody feels bad if a technician or assistant calls them instead of the doctor. And I think maybe part of that is because I've worked with really lovely, wonderful doctors who are almost always willing to get on the phone when they're needed with a client. And so the clients know that they are in good hands, and they know that the person that they're putting on the phone is someone the veterinarian trusts to have that conversation.
And I think that's so critical because to me, the client will follow your lead. as the doctor, if you're saying, if you sort of set that expectation that I'm the only one and I'll always be talking and I'm here for you, like you're not allowed to resent that when you're the only one they want to talk to. And so
Right.
if you set up this expectation, I have this incredible technician who's going to be calling you after and, walking you through everything. And if there's any more questions, I'd be happy to answer them. Like, to
Right.
me, that seems very straightforward, but you're the one who takes the lead on that. That's training your clients and yourself.
That's exactly right. You're 100% correct. And now, especially nowadays, I think people are so much more used to now talking to the nurse or medical assistant on the phone rather than the doctor. And I think that, human medicine yet again is leading the way for us and helping pave that way to make it easier for us because they are training our whole client base, right?
Yeah.
And this is a moment that we can use to take advantage of that, to start translating that into on the veterinary side.
So one of the things that I think is really interesting is the doctors are saying, well, you're telling me I should charge, right, to get on and do this visit, and I've never charged. So, I can't just start doing it now when I haven't been doing it forever. And so to me, again, it's sort of this whole thing that you haven't been doing that you can start doing right now if you actually start utilizing your technicians and your assistants or training them. So if they do that, then they're still answering those questions that they wanted answered. And maybe you don't charge for that because that's always been a service that you provide. And so
Yeah.
you're not all of a sudden, taking away something that they've had and charging them for it. Like, you're still offering the service, but now you've set aside, if I get on, like, this is a big deal and it's going to be a scheduled visit.
Right.
And
Right. And I think
like
that's I think that's a really interesting way to look at it, to think about the switch over to it. It's like, for practices who aren't doing telemedicine at all right now, that's a huge switch just to start, right? And the idea of jumping immediately to a video visit that you're starting to charge for when you haven't never charged for a phone call before, you've always done emails, for follow-up for free, none of those things you've charged for before. It's a whole new area to think about. And that may be, for those practices, that may be too much to also add in the piece of letting technicians do some of those things. But for those practices, I would suggest to them that they use their technicians and assistants as the facilitators of the communication with the doctor. So they are the pre-screeners. And I think some folks maybe, and I'm not as involved in the back end of all of these practices who are starting to move into this world right now. But I think a lot of those folks are using their CSRs or their front desk staff for that instead, because they're treating it like a scheduling issue.
right.
And I would suggest to them to take that off of the CSR's plate and put it onto an assistant or a technician's plate instead. Again, it frees up your CSR to do the things they are the best at, which is providing a really wonderful service experience for your clients. And it lets the technicians and assistants use their medical knowledge to help get the exact information that the doctor is going to need if they need to make that call. So I think history gathering, setting up the client's expectations, letting the client know what they're going to need to have ready for that appointment, and kind of getting them in that mindset of what talking to the doctor is going to look like if they in fact need to talk to the doctor. So I think that practices shift that scheduling function or pre-screening function over to the technicians and assistants, I don't know, it might backfire. They might find that they actually don't end up scheduling as many calls because the issues maybe are taken care of. So, but I think if you do some, some rubrics, if you're measuring that, then it can start leading you down a path of, oh, it looks like now we should be charging for these technician calls that we haven't been charging for before.
Yeah, it's interesting because it seems like the perception of value from the client's perspective comes when, is it scheduled? If it's scheduled, it's something valuable and I'm willing to pay for it. But if somebody just grabs the phone, then obviously they were just sitting there anyway, hanging around.
Right.
So nothing better to do.
Right, exactly. And it's, you know, it is interesting, the parallels and the differences between human medicine and veterinary medicine, because I'm a part of Kaiser, that's my healthcare. And you can, it's part of your plan. You can call and talk to a nurse 24/7, anytime you need help. But even in that situation, there is a screener before you even get to the nurse. So there's someone who's picking up the phone, talking to you to determine if it's really a medical issue and you need to talk to the nurse. Then you talk to the nurse and the nurse decides, oh, this is something you actually need to be seen in person, or we need to set up an appointment with your doctor. So that call is free, but then the doctor visit is, you know, your copay or whatever it might be. We can take some lessons from that, I think.
No, and it's true. And I think the people that are getting a lot of pushback from the clients, it probably is because the person's like, I just had a question. Yeah. And the doctor's saying, well, I'm charging for my time now. And I think there's just that one missing step. Like literally, if they just want to know, can I refill?
Right.
Right.
Can I get a refill on this? Can I get a refill on my Rimadyl prescription? Can I get, do I really need a heartworm test, or can I just get more heartworm medication, you know, to get me through the next 2 months? Do I need an actual doctor visit, or can I just come in for a blood draw so that I can get a refill on my phenobarbital? Do I need an actual visit with the doctor to do that? Or does the doctor just want to look at the blood values so I can come in for a tech appointment, which again, practices, if you're not doing that yet, you should be doing tech appointments. Draw the blood, right? The doctor looks at the blood work, determines if everything is okay. If everything's not okay, then you're into the revenue generating area. Well, double revenue generating, because you already did the blood work. But now you're into, we need a visit, and that can be a video. That's a perfect opportunity for a video visit to say, hey, this blood work is off. Here are the next steps that we need to do, and here's how I want you to adjust the medication. Or I really need to see this patient to see what's going on because the blood work doesn't make sense with what you're telling me, and so we need to have a visit. So I think for people who are new, that's a really great way to start doing it. For people who are more experienced, you have a good crop of technicians and assistants in your practice, you're already utilizing them well, they're experienced, you can take that to a next step further. I worked with doctors who were very comfortable allowing their technicians to call back clients and pet parents if there was an issue with the blood work, to discuss the issues with the blood work and what the next steps were, which were usually, we're going to need you to come in because this is what we saw in the blood work. That is so much more valuable to a client than just having a CSR call and say, the doctor wants you to come in for another appointment, because the CSR can't explain the reasons why that appointment is needed because they don't have that medical background. So that's a next step. And then if you wanted to take it a step further, depending on what your crop of technicians and assistants are, what your team looks like, then you can start using them as referrals. So you use them as experts in whatever area it is that they're expert in, and then you start charging for their time for that. So maybe you have a technician who really loves behavior, right? You could schedule and make money, like good money on
especially
a 30,
now.
Oh my gosh, a 30-minute puppy visit, right? Let's talk about puppy mouthing behavior. So put it on video, right? Let me see what's happening. Let me see how you're interacting with the puppy. Let's talk about some ways to manage this. Let's talk about how we can fix it. That, you know, that could be an hour-long appointment, and you could charge someone, I mean, I'm in California, you could charge someone $60, $65, $70, $75 for that hour, where they have a dedicated person who's focused on their animal's behavior and helping them manage it. That's huge. That's $75, and you're maybe paying your tech $20 an hour. You know, so that's a big profit that you're making off of that. Much bigger profit than you would make if the veterinarian was doing that call.
You're
And
like,
most veterinarians don't like doing that.
spray him with some water. Like, I don't know.
Right. Veterinarians don't like doing that. And honestly, there's some techs who don't like doing that, right? There are some techs, like I love behavior, but I'm not very good at it. So, but put me on the phone with someone who's trying to give puppy fluids to their cat, right? And what's the best way to do it? And how, oh no, change your angle a little bit. You're not doing that quite right. Oh, you might need another person. Your cat's really squirrely, whatever it might be. But there's no reason for a veterinarian to have to spend their time doing that.
That's a really interesting point. I worked at a lot of hospitals where if there was something you were really good at, then you almost talked about that less because they wanted to focus on the deficiencies they wanted to train you up with. And then I went to this one hospital that had one technician and she never went in the room with clients. Like that's not her thing, and I was like, okay. Yeah. But she was the lab tech and so good at it. And she loved cats. Like she would go into a cat room and just, like, and the fact that the management sort of figured out like, oh, let's play to that strength. It made such a better outcome for everybody.
Right. And then that technician feels so much more valued. They feel like management knows them, recognizes their strengths, values their strengths, and isn't going to put them in situations that they don't like, that stress them out, that contribute to burnout. Let them do what they love and what they're really good at. And I guarantee you, managers, if you talk to the rest of your staff, you will find the things that they really love to do and want to do more of. And then you can use people for that. So the referral thing, I think, is a huge step. It's a big step. If you're just dipping your toes into telemedicine, you might think that's going way too far. But I think for those of you who are doing telemedicine already, you're comfortable with it. Think about ways to leverage your staff, your technical staff, your assistants, your technicians, to do those things that they're really interested in, and they can become profit centers for your practice if you let them do those things.
So you mentioned step one was starting with the healthy callbacks. Let's say that you are interested in having your technicians do triage, but you're not quite sure that you have the training down. Like, what would be a good next step for that?
Yeah. So I think there are a couple ways you can do it. It depends on your staffing and what your training situation is already like. There are some really good resources online, CE resources for basic triage. We do learn basic triage, but if you're just a general if you're a general practice, if you're not an emergency or specialty practice, you may not have a lot of experience with triage because it's not something you're doing every day as you would in an emergency practice, for example. So the vets are probably rusty at it also, really. And you forget. I know working at this general practice, they didn't see a lot of emergencies. So then when a trauma would come in, a hit by car, a snake bite, whatever, it's hard to put yourself back in that mode, going back to your emergency rotation when you were in vet school, to remember what it is the steps you need to take when you're faced with, an open fracture, a snake bite, whatever it might be. So that's in-person triage, which is a whole animal in and of itself. And then the teletriage, I think, is something, again, the classes can help. So there are lots of in fact, there's a class on BSPN that's about to start, taught by a VTS in ECC in triage. And there's a whole, I think a 3-week class, and one whole session is on teletriage. So how do you talk to clients on the phone? How do you figure out what's going on? How do you convince a client to come in, that it truly is an emergency and they need to come in? Technicians, I think, are perfectly positioned for triage because for teletriage, because we're doing the triage oftentimes in person also. So it's pretty rare case that a practice would have a doctor go straight into a lobby or straight out to a car to see what's going on with a pet. Usually it's going to be, hopefully not a CSR, but an assistant or a technician who's going and taking that first look. So when we think about it being on the phone, it's the same thing. And really, when you stop to think about it, it's something you're already doing right now. And in many cases, the doctor is doing it, right? If the call comes into the front, my dog is vomiting, they put a doctor on the phone and the doctor is doing that triage. When you want to train a technician or an assistant to do that, there are a couple ways you can do it. And I think I'm a big fan of phase training or you know, don't throw someone into the deep end of the pool. So don't put someone in front of a phone and say, you're going to start taking these teletriage calls. So pick if you right now your practice has only doctors doing these calls, pick the doctor who does it the best, who is the most empathetic, who is the best communicator with the clients, and who has a good success rate in sussing out, you know, asking the right open-ended questions and combination of open and closed-ended questions to get the information that you need, and have the technician or assistant shadow them for a week of calls, right? So every time one of these calls comes in, that technician or assistant comes over and listens to the doctor do the call. Maybe they get on the line at the same time. Maybe they just stand by and listen. And then after, you can talk about, the doctor can talk about why that worked, what went well, what didn't went well, how could we do that better in the future. The next phase would be letting that technician or assistant start taking those calls with the coach nearby, so whoever that coach may be. So if you have a well-trained staff and you have people who are already doing this or who have done this before, you could do this training with a technician or an assistant if they're already doing it. If you haven't started doing that and the doctors are doing it, it's going to have to be some doctor time. The investment in the time that you put in, right, to do that, to get it started, just like everything with training, that if you invest good time at the outset, you get a hockey stick graph, right? It's not a slow, steady rate of growth and education and experience. It's really quick, right? Once you invest that time in the training at the beginning, and I know it's hard, it's really hard to convince ourselves that that is what's important. But it really will make a difference in the long run, allowing those people to start doing it more on their own. So it can be the doctor, it can be a technician or an assistant who's already trained in how to do it. They can listen, coach that person through a call, either by being on the phone or just sitting next to them while they're doing it. Troubleshooting in the call as it goes, debriefing after. And I think the more you do that, the more experience people get, then the less supervision they need, just like any skill that you train. I think the most important thing when you're starting to train people is to let them know that if they have a doubt, if there are any questions, they need to have a person that they can go to that can help them. So you can't throw someone in and have them do this kind of in isolation in their own like separate room, trying to work this out on their own. It has to be clear that there are always places that they can go to get the help that they need, that someone could tag out for them if they're, you know, if they feel like they get above their head. So then it becomes really important that you pick the right people to do the job, because you don't want someone who is going to go kind of rogue. You don't want and I have seen this, right? You don't want technicians out there giving diagnoses over the phone, saying, oh, this is what this is. You don't need to do anything, right? You need, which is why I think that the people doing this in practice, there's a temptation, I think, to put your least experienced people on calls because they don't have the technical skills. They can't do the stuff in rooms, whatever it might be. But in reality, it needs to be your most experienced people, because those are the people who know enough to know that they don't know a lot. And you have to bring a level, I don't want to get too like woo-woo or anything, but you have to bring a level of humility, I think, to it when you do, as a technician, when you're doing these calls. It's a really difficult balance between your experience, what you think might be going on. You don't want to panic the client, but you also want to communicate an appropriate level of concern or urgency, whatever that might be. You don't want to give them false hope. And so it really does take a lot of trust for the doctor to put this in the hands of a technician. And it has to be, I think, the right technician. And I've worked with people, I know people, you know, who maybe would maybe go a little bit beyond what they should as a technician when they're doing triage. We all know these people, right? We've worked with these people even in person. So the same things that apply in the clinic apply when you're doing it on the phone as well.
Yeah, people's basic personalities don't really change all that much. But that's not a problem, right? With telemedicine, that's just a problem with
that's just a problem in exactly with medicine in general. But I think there is a risk, right? Yeah. I mean, I'm a huge proponent of telemedicine. I think we need to be doing it more in veterinary medicine. But I do think that there are risks the risks are maybe not the same for a DVM or an RVT, CVT, LVT, but there are risks on both sides. So, you know, I think, and this is what we hear. This is what we hear of the downside of telemedicine is, you know, oh, my dog was vomiting. The vet told them to give Pepto-Bismol, and it turned out it was bloat and they died. Well, you know, I don't know what to say about that. I don't know anything about that.
No, you know, I know exactly what you're talking about. And I guess for me, so here's my response. So I've been online for 11 years and I have been crystal clear. I do not practice medicine online, right? And to me, when those boundaries are there, that's fine. You stick with them and people respect that. And my response to that is for every vet who gets it wrong, there's 50 people on Google telling you something way worse. I remember that, and that's really what we're fighting against, right? Like that one veterinarian, like this is a training issue. We can work through that. I cannot work through Google. I remember the first time somebody brought in a home bloat kit, and it still makes me cry to think about it. They printed off a message board. You go to Home Depot, this is the tubing, and this is what you do. And you know, like, you know, what?
Terrifying.
How can we, like, we need to remove as many barriers as we can to accessing good advice.
100%. And so, like you said, it's a training issue, right? And I think it's a training and an education issue and an experience issue, really, because the longer you work in veterinary medicine, the more you see, the more you're exposed to, the more options come to your mind when you're doing these telemedicine consults. And I think about a case that I had where a woman called and said, oh, I have a lab. He's walking around. He won't lay down. He's not comfortable. He's retching, but nothing's coming out. He's not vomiting. He keeps looking at his side, you know, and he just won't settle. And I was like, okay, you need to come straight to the hospital and we'll see you soon. And, you know, 20 minutes go by, 30 minutes go by, and they don't live that far away. And I call them back and they're like, and they say, oh yeah, we were on Google and we were searching and we thought, you know, we were looking and it sounds like maybe this is bloat. Do you think this could be bloat? And I realized I had made an error in my original call. I didn't do a good job of talking about the potential. I don't have to make a diagnosis, and as a technician, I can't and absolutely shouldn't. But I can give a range of things that might be going on and be more communicative of the urgency. But I think that's an experience issue, right? So that has always stuck with me. And so now I always try to be careful of communicating a level of urgency that is appropriate for the situation. But on the training side also, and kind of like that, right? And so I shared with the telemedicine group my flow chart, which I think is something really useful for CSRs because it's kind of an immediate yes or no. Do they need to come in, not come in? And there's always going to be some nuance, but sometimes that flow chart is enough to get somebody in the door, and you don't need to do any more because once they get there, you'll be dealing with whatever it is that's going on. But I think having protocols and
Yeah.
not necessarily conversations or trees or algorithms, it depends on how geeky you want to get with it. But I think having those protocols is
Yeah.
really important. So standard operating procedures, whatever you want to call it. So at my old practice, for example, we did have over-the-counter medications with dosing that we could give to clients, because that was something that the doctors had already agreed on. So in California, we determined that was indirect supervision, which is the definition of indirect supervision. They're either there's a written protocol that the doctor has prescribed, whether that be over the phone or, you know, something they've written previously that the technicians can then follow. I think of bee stings as a big one, because I used to get a lot of calls about bee stings, and some dogs, I have a little dog who got stung 2 weeks apart, and the first time was your usual, you know, it got a little swollen, she was painful, whatever. And then the second sting 2 weeks later, she went into full anaphylactic shock. So you can take care of that on the phone, and there really isn't a reason for the doctor to be on that call, right? But you can have a protocol that says, here's the dosage of Benadryl, right? We dose it by weight. So here are the weight ranges. Here's give a Benadryl. And then here are the signs to tell the client to look for that would necessitate a visit to the hospital. And if the Benadryl doesn't work or any of these signs manifest, the owner already knows they need to come. They don't need to make another call. And you've saved the doctor from having to get on the call for something that could be a really simple, straightforward thing. And you've saved them from also having to have a conversation with their technician about determining the dose of an over-the-counter medication, because you've already done it before. So I think that goes a long way.
It does, and I think that's a really good point about those standard operating procedures, because, you know, triage isn't just, well, I think, you know, this, that, or the other. And I think a lot of people get tripped up when it comes to that VCPR thing, and the fact that you can't make a diagnosis. That doesn't mean that you can't list out some possibilities. And like you said, I think that's super, super critical. For me, when I'm sort of trying to figure out that workflow in my head, it's kind of like what you were describing for people. When the first person is the CSR, right? So I have your do not pass goes. You don't have to wait for a technician if my dog's having a hard time breathing. Like, okay,
come on down.
Or come on in. And so, you know, those things seem like, okay, you can train that. And then you don't want that poor CSR to have to do the rest. The vomiting one is the gray area, right? There's like obvious red lights, obvious green lights, and all that gray area. So that's where the technicians are super, super good at.
I think the technician is the gray matter separator, right? They're the person who, like, just like I used to do when dogs would come in and they ate something and we had to make them vomit. I used to sort through the vomit and separate it out into its constituent parts for the doctor to come and look at and say, right, exactly. Because doctors don't want to do that. But I actually enjoy it, getting in there, sorting out the messy stuff, saying, okay, here's the, you know, the rat bait or the green stuff. These are pieces that I think are probably greeny. Here's their food. Now you can figure out how you want to go forward. So that gray stuff, that indescribable tele-advice, tele-triage stuff, is like the vomit of telemedicine, and let your tech sort that out for you.
Matter description, right? So you're all that important stuff in the middle, and we're like the layer on top, right?
That's
and then
exactly
you've got your amygdala back there, which automatically reacts. Oh my God, this is perfect. I think we have a new model.
Let your technicians and your assistants sort through all of that stuff and give you the essence of what it is that the doctor needs to take care of. So, you know, we all know there are 4 things that the doctors do, right? They do surgery, they write prescriptions, they come to and deliver a prognosis, they come to and deliver a diagnosis. Those are the 4 things that only doctors can do. And so my job as a technician, I feel, is to make sure my doctors are doing only those 4 things as much as possible, and taking the other things off of their plate as much as is legally and logistically feasible for me to do.
Yep. Oh,
And
that is.
telemedicine, teletriage especially, is the perfect place for that. And,
Yes.
you know, I think about that every time I talk to a practice manager who says, my CSR spends so much time on the phone with clients. They're, you know, because they're using their CSRs in that role, right? To figure out if a prescription can be renewed, figuring out if a visit needs to happen, then, you know, going back and forth between being on hold with the client and talking to the doctor, coming back to the client, talking to the doctor. Why are you using your CSRs for that? It should be a technician or an assistant, and let the CSRs do the things that they are really good at.
This is the longest conversation I've had, but like it's been amazing because to me, I keep talking about this, like, what's the secret sauce of your success? And this is it.
Yeah.
You know, I
Well,
think
utilization,
yeah.
is it, period. I think when you look at the most successful practices out there, the thing that they're doing differently is they are fully utilizing their staff as much, you know, using their staff in the roles that they're good at, that they enjoy, and fully utilizing them to every extent that they can. And this is just a perfect extension of utilization and figuring out the best places for people to provide the most value to the practice.
Well, thank you. Thank you so much. And I'm going to find the tree that you had shared and make
I
sure
can send it to you again.
Okay.
Yeah.
No, I know you did way back at the beginning, but people are going to see this and say that they want it again because we love flowcharts. It's super awesome. So yes, don't forget about your gray matter. Like, your brain needs all of it. It needs your cerebellum and your amygdala.
Yeah, it needs your forebrain, it needs your eyes
it.
and ears, right? It needs, and then it
Works
needs
together.
that processing power in the middle to sort through the BS and deliver exactly what it is that the cerebrum needs. Yes.
Thank you for being the gray matter that keeps vet medicine functional. All right. Well, thank you. Yes, thank you again. This has been incredibly helpful.
Thanks, Jessica.